Mr. Shobin Varghese. The head of our department has played a major role in coming up with creative ideas and by remaining a constant source of support. I invite Shobin Sir to welcome the gathering.
Parambil, Director of Self-Financing Courses, SB College, Dr. Hcg Given, Coordinator of today's program, respected teachers and students. As we all know, the world, especially Kerala, is going through some unimaginable situations, pandemic-related difficulties. The people of Kerala has witnessed some and some of us has faced some disastrous events. But even in these situations, we hope for a good future, and we hope the pandemic will soon be over. We hope all of us have a happy life from now on. And I am happy to welcome our key speaker, Srimati Shahana Syed, as our key speaker today. How she helps many people to complete their family, many to become mother and father, really make her a true ambassador of hope and happiness. Welcome, ma'am, to the occasion.
Thank you.
It's my great pleasure to welcome Reverend Dr. Teddy Kanyu Parambil, Director of Self-Financing Courses, SB College. He is very much part of the Biotechnology department in every aspect in his guidance and constant support. Welcome, Father, to the occasion. And I congratulate and welcome Dr. Hcg Given, the coordinator of today's program. And through her, we have got the opportunity to meet Srimati Shahana Syed. Welcome, ma'am.
Thank you.
And I welcome all the teachers and students from SB as well as other colleges who have joined here. And I am sure it will be a fruitful session for all of you for a better tomorrow. Thank you all.
Thank you, sir. It is my honor and privilege to introduce to you our speaker of the day, Ms. Shabana Syed. She is the Laboratory Director and Senior Clinical Embryologist at Klinik Hcg chain of IVF clinics in Norway. With over 21 years of experience and has been instrumental in proposing international guidelines for annotations in time-lapse imaging in IVF. Her career in IVF started in the early 2000s, and she has been the head of Ivf Labs at Klinik Hcg since 2008. She also heads the clinical and research division of all 4 branches of Klinik Hcg in Norway. She has academic degrees in molecular biology from Mahatma Gandhi University and specialization in clinical embryology from Australia's Monash University. She is currently pursuing her doctoral degree in clinical embryology titled Time-Lapse Imaging of Human Pre-Implantation Embryos, a predictive tool in the IVF laboratory and clinical practice. Her doctoral thesis evaluates the role of early biomarkers in time-lapse imaging of IVF embryos for predicting implantation and live births in IVF. She is also the author of several peer-reviewed articles and has been contributing her knowledge and expertise through her presentations. It is with extreme pleasure and gratitude that I welcome you, ma'am, on behalf of our department. Over to you, ma'am.
Good morning, and thank you so much for the lovely introduction. And thank you, Dr. Liji and the respected teachers for inviting me to this lecture. I hope my voice is clear.
Yes, ma'am.
Okay. So, before I start, I would really like to thank all of you for attending this meeting and my intention today is basically to give you an overview of what we actually do and how we do things to make sure, like the head of the department, Dr. Shabana, said, to make a difference in somebody's lives. So it is a giving profession, but of course it also has its ups and downs, because you're trying to give hope, and especially you all know now during this pandemic, hope is what keeps us alive. And it's hope that, you know, that maybe in a few months' time, we are going back to normal classes, meeting your friends and having a good life. And that's the most important thing. So I will now start my presentation. If you have any questions, please feel free to ask. It's a bit too early here, so I'm just waking up. So if I speak, I'm known to speak very fast, which Dr. Liji will definitely say, but I'll try my best to talk slowly. And if some of the slides are not clear, just make sure that you ask me in the end. So over to the presentation. Is the slide clear? Can you guys hear me?
Yes, ma'am.
Okay. So assisted reproductive technology, or ART as it's commonly known, is basically from the word suggest, it is assisting reproductive technology. So today I'm trying to explain what ART actually means, what's the history behind it, how does eggs and sperm quality matter, and what really happens in an IVF lab. And at the same time, how do you define success? Because that's an important factor. So infertility, or the inability to have children or conceive, is a growing epidemic. The WHO has actually defined it as an epidemic now, because 49 million people across the globe suffer from infertility. Countries like Norway define infertility as a disease, and that basically means that you have every right to get a cure to treating your infertility. Infertile or subfertility basically means that you have a problem to get pregnant or to conceive and have a baby, and how do you actually define somebody as being infertile? If you're less than 35 years of age, then if you're not able to conceive within 12 months of actively trying, then you say that it's time now to meet an infertility specialist. If you're over 35 years of age, and if you're unable to conceive in 6 months of time or trying, then it's time to start. And this cutoff of 35 years is quite important, because if you ask me, 35 in a normal sense of the word is not too old. But in a reproductive aging sense, 35 is the time when it starts actually declining. And it's estimated that around 80 million pairs are involuntary infertile. There's a difference between involuntary and voluntary infertile. Involuntary infertile basically means that you have a wish to become parents, but you're not able to become parents. And it affects around 8 to 12% of couples worldwide. Just taking the case of India, almost 18 million Indians suffer from infertility. There could be a number of reasons for infertility, from everything from genetic to alcohol consumption, smoking, stress-related factors, and so on. So just an overview about what can cause infertility. Infertility can be due to female factor and male factor, and actually quite similar. It's not just the female factor that causes infertility, but both factors can equally have an effect. In some couples, it can be a combined factor, that there could be a female factor and also a male factor. But in 20% of the cases, you really don't know the reason behind an infertility, or the reason behind why they don't conceive. And that's what is called as unexplained infertility. And that's actually the most difficult one, because when you know that what is the reason, then you could literally cure it. When you think about female infertility, or what are the factors that can cause female infertility, it could be a number of factors. For example, acquired factors like stress, getting married quite late, trying to have children quite late in life. It can also be factors like the tubal damage. So, the fallopian tubes can be blocked, maybe due to a previous chlamydia infection, ovulation failure, and so on. Sometimes you can also have girls that are born without a uterus, and the uterus or womb, as we know it, is where the baby has to implant, and the embryo has to give rise to a baby. A number of male factors from born with undescended testes, having infections, and so on. When you think about this article from India, this was published in 2021, actually 2 months ago, by a group of Indian epidemiologists from Assam. And this is based on the National Family Health Survey that was conducted in 2015 and 2016. And if you look at the prevalence of infertility among married women in India, you can see that it's increasing. So what is written as NFHS, it's the National Family Health Survey. It's conducted as a part of the census. And if you look at the prevalence of infertility, and just before I forget, there are 2 types of infertility. One is a primary infertility and the other one is secondary infertility. Primary infertility literally means that they have never ever had children. So they've never ever conceived. Whereas secondary infertility, they probably didn't have so much problem conceiving the first child, but then they have a problem conceiving the second child. So this survey is about primary infertility. So in this one, you can see that the southern states have an increasing prevalence of primary infertility, and that's quite interesting. Because if you look at the other parts of India, the infertility is prevalent, but in the south, it's more prevalent. What could be the reason? Probably higher education, so that people are more aware. They're also aware of getting treatment. It can also be that you're more educated, so you want to have children a little bit later in life, stress factors. And one of the things that they have actually mentioned is that it's stress related to job and getting married later that could be a reason for the prevalence. So what is actually ART? ART, or as the European Tissue and Cell Directives describe, is the medical use of biotechnology in humans. So basically, you're trying to put in medical biotechnology to achieve an end. And it can include anything from donation to distribution and testing on cells, human cells and tissues. A bit about the history of ART. How did this new branch of science or medicine start? It's a part of actually the gynecology and obstetrics. And the first baby born was Louise Brown. I'll show a video and let me know if the video is not clear.
Meet Louise Brown. Louise works in the post office and she likes playing darts and swimming. She's now 34, and when Louise was born in 1978, she was the most famous baby in the world. Just a few days old, she was on the front cover of newspapers and magazines. Louise was famous because of something that had happened 9 months before she was born. Louise was the first test tube baby. You might think that a test tube baby is grown inside a test tube, but what it actually means is that the baby was conceived in a special way. Usually, conceiving a baby starts when an egg ripens in the mother's ovary. The egg travels down a tube leading from the ovary to the uterus or womb. Along the way, the egg meets up with sperm, which has come from the father during sex. This is called fertilization. After the egg and sperm join together, they make a collection of cells called an embryo. The embryo eventually grows into a baby inside the mother's uterus. But for Louise's parents, Leslie and John, there was a problem. Leslie had a blockage in the tube that led from her ovary to her uterus. Her egg couldn't get through, so John's sperm couldn't meet up with Leslie's egg. Leslie and John had wanted to have a baby for 9 years, but because of the blockage, Leslie's egg couldn't be fertilized in the usual way. Leslie and John's doctors, Robert Edwards and Patrick Steptoe, had been working on a new technique that they thought could help. This technique is called IVF, or in vitro fertilization. The word vitro comes from the Latin word for glass, so IVF, or in vitro fertilization, means fertilization in glass. The idea was that the doctors would take a right egg out of Leslie's ovary. Then they would mix it with John's sperm in a glass container called a Petri dish. The sperm and egg would fertilize in this glass container, in vitro fertilization. Then the doctors would put the embryo back inside Leslie's uterus, where it would grow into a baby. Although we call babies conceived using IVF test tube babies, they are actually conceived in a Petri dish. Getting all this to work was very difficult. Each stage in the IVF process needed to work. When was the egg ripe enough to be gathered? How could the sperm and egg be kept alive and healthy in the Petri dish? And what was the right way to put the embryo back inside the mother? After working together for 10 years, Patrick Steptoe and Robert Edwards thought they had solved all the problems. Leslie and John thought they would try IVF to see if the technique would help them have a baby. It worked. Louise was born on the 25th of July, 1978, in Oldham General Hospital. She was healthy and just the same as other babies, except that she had been conceived using IVF. Not everyone thought that IVF was a good idea, though. Some people were worried that test tube babies would not be as healthy as naturally conceived babies.
So, yes. So to continue, so you saw how the first IVF baby was born in 1978, and from that time onwards, there are almost estimated more than 7 million ART babies are born. And the icing on the cake was actually when the Nobel Prize in Medicine was awarded to Sir Robert Edwards for his work and for creating this completely new branch of medicine in 2010. So when did IVF start in India? It actually started quite early. If you remember, Louise Brown was born in July. The first undocumented IVF baby was born in 1978 in October. But because it was undocumented and the experiments were not made available, official IVF baby, or the first IVF baby, was born in 1986. It's quite interesting to learn about Dr. Subhash Mukherjee's work, and a number of milestones happened all along the way. So you know that when the first IVF baby was born, it was literally by a natural conception, which basically means that they have, I think I have a problem with, I'll just try to, yes, I'm sorry for that. So later on, the doctors found out that it is quite possible to stimulate women and try to mimic the natural menstrual cycle and try to get as many good quality embryos as possible. But that also resulted in having a lot of good quality embryos. Rather than throwing them into the waste basket, you wanted to freeze these embryos and make sure that the frozen embryos are no longer different from the normal ones. So all these shows the different milestones IVF has come a long way from 1978. And even now, even with fertility preservation, so if you really have early cancer, you can preserve your testicular tissue and your ovarian tissues for future use. So there's always hope. So assisted reproductive techniques, that's the history. And where do we stand now? IVF or ART. ART is often misunderstood as IVF, but IVF is just one type of ART. And there's a lot of techniques. I'll go through some of them. So what are we trying to do here? We're trying to mimic the ovulation, fertilization, implantation procedure. So ovulation basically means that you have an egg that's produced in the ovary here, and this egg, when it is mature and ripe, should be released. When it is released, the tube, or the fallopian tube as it's known, will pick it up. It travels all the way, gets fertilized by the sperm, and then the embryo that is formed as a result of this fertilization moves down and gets implanted in the uterus or the womb. It's not just a simple process, because you can see it takes quite a number of days for this embryo to be implanted. Implantation basically means the embryo now tries to attach to the uterine wall and stick there for the next 9 months and result in a baby. It also involves the action of a lot of hormones. The hypothalamus, pituitary, and the ovary interactions and the hormones are very important. And what are the hormones that are quite important? You have the follicle stimulating hormone, or FSH. You have the LH, that's a luteinizing hormone, the estradiol, or E2, and the progesterone. So how does it mimic? This is how a woman's menstrual cycle characteristics are. So you start in the beginning, that's the start of the follicular phase. The follicles are very small. Just to be clear, what are follicles? Follicles are actually like sacs, or you can say like bags inside the ovary, and the eggs grow inside these follicles. So the eggs are quite small. They're like 0.1 millimeter or less. So basically what you're trying to do is you're trying to say, oh, the follicle is this size, so I assume that the eggs inside them are also quite big. So in the beginning, in the follicular phase, the FSH increases because that's a follicle stimulating hormone. The follicles grow in size, and as it grows, the egg inside also, you can see the size increasing. When the egg is completely mature, then you want it to be released from the ovary. Then the FSH goes down because it has done its part already, and then the LH, or the luteinizing hormone, takes its role. So you can see that there's a peak of LH, and when the LH peaks, it's time to ovulate, or time for the egg to be released. And once the egg is released, then it's time for it to meet the sperm and get fertilized. But what happens to the rest of the follicle? The rest of the follicle starts shrinking. It ends up in what's called as a corpus luteum, or you would have heard the term yellow body. And that actually produces the progesterone. So as the follicle grows, the FSH is important. For ovulation, the LH is important. And as the follicle grows, it produces estradiol, which is important for maintaining the size of the follicle. And once it is released, then the progesterone takes over. And why is the progesterone important? Because progesterone is that maintains pregnancy. So the corpus luteum provides the necessary progesterone. If pregnancy doesn't happen, then the progesterone goes down. You get a menstrual cycle, and then the next cycle of FSH, LH increase takes place. At the same time, when the follicles in the ovary are increasing or becoming bigger and riper, the endometrial lining, which is actually the uterus lining, also increases. You can see that when it starts, it doesn't have so much of blood cells or blood vessels, but as you can see, as the menstrual cycle progresses, the blood flow increases, and the blood flow is important because you need the embryo to stick there. You need the mother to provide all the nourishment to the baby. And if it doesn't happen, then you get the next menstrual bleeding. So this is what happens. And this is what basically you're trying to mimic in an IVF cycle. So normal menstrual cycle, woman or a young girl produces normally one big sized follicle. But in IVF, the intention is to have a lot of follicles because you need a lot of eggs. So what you do is you give them a stimulation of the ovary by giving extra injections of FSH. And when you measure them with ultrasound, you see, and this can be going on until 10 to 15 days. It depends on how a woman responds to the injections, how big her follicles are. And when the follicles are bigger, then you give an LH injection, or what you normally give is an HCG. It's a human chorionic gonadotropin injection. HCG has an LH activity. And why is HCG given? Because it has a longer shelf life or a longer activity period. Then you take out the eggs, do all the fertilization in labs, in petri dishes, put the embryo back and give a progesterone supplementation. And then you wait for the pregnancy test. So basically the whole process of IVF involves hormone stimulation to produce more follicles, and ultrasound monitoring to see if the follicles have become bigger. Is it time for ovulation? You collect the eggs, you prepare the semen, you do the actual insemination, develop the embryos, transfer them, and if you have excess embryos, then freeze them. So this is like a live example. So you can see in the beginning, she's gotten her whole set of injections. These are the follicles that the doctor can measure from the right and the left side. That's why there's a difference in color. And you can see after 10 days of stimulation, they're quite small. So you continue stimulation, and now you can see the follicles are quite big. You normally say that if the follicle size is around 20 millimeter, then the egg inside should be ripe. Then she is given a trigger or an ovulation trigger, and then the eggs are collected. Please let me know if something is unclear, okay? So what happens in the follicle development? When the doctor does an ultrasound, this is what he normally sees. This is the ovary. You have a lot of follicles, and these follicles are the ones that we are measuring. What does a follicle include? If you take a cross section of the ovary, you can see that the follicles keep on increasing. Here it's completely mature, it ovulates, the egg is released, and then it turns into a corpus luteum and shrinks off. The follicle looks like this. It's got a large number of cells around it, and these cells are very important. I think you might have learned about gap junctions, crosstalk. The egg and the cells outside does a crosstalk, and the crosstalk is dependent on a lot about FSH, LH receptors, and so on. And the egg inside is inside a cavity which is filled with the fluid. So this follicular fluid provides nourishment to the developing egg. You can see the egg literally hangs into the follicle, and this is how an egg literally looks like. So just I think you might be interested just to know a bit about the genetics of how all these things happen. You have the follicle development happening all along. And if you really think about it, just before birth, a baby girl is born with all the follicles or all the oocytes that she's ever going to have in her whole life. So it's not like the sperm or the spermatogenesis, because the sperm production starts from puberty. Whereas in a young girl, she's already born with all the eggs that she is going to have her entire life. But they remain inactive in childhood. But from puberty, when she gets a menstrual cycle, it starts developing and maturing. And if you remember meiosis, it goes through both meiosis 1 and meiosis 2. It stops, or it gets arrested at meiosis 2 in its metaphase 1. And when the sperm comes in, it resumes its meiosis and gets fertilized. It's also interesting to see, because if you look at all these things, or all the initial stages, they're all diploid. But we know that when you finally have an oocyte or an egg oocyte is the scientific term for eggs. It has to be a haploid one, because when it meets a haploid sperm, you have to have 46 chromosomes or the 23 pairs of chromosomes in a zygote. Otherwise, it's chromosomally abnormal. So as the follicle grows, this is what happens with the oocytes inside. So does oocyte quality matter? This is how a normal good-looking oocyte should look like. In these cases, you can see that the oocyte quality are literally different. Some of them have genetic abnormalities. You can see cytoplasmic abnormalities, and genetic abnormalities are normally not good. Why? Because you can see that, you remember when I said 35 years is important, it literally means that from 35 years of age, then your chances of giving a live birth literally goes down. So if you look at this graph, from 35, you can see that there's a drastic drop in your ability to form your own or have your own child. At the same time, if you use donor oocytes, or if you have oocytes from younger women, then you can see it doesn't fall that sharply, which literally shows that the age of the woman is a very important factor. And why is it important? Because you can see again in this graph, this is the UK fertility treatment graph. As the age goes on, increases, the live birth chances fall off. So if you're around 40, 45 years, then you have literally less than 5% chance of naturally conceiving. You can also think that you can naturally conceive, but your miscarriages increases. And that's because the aneuploidy rate, or the chromosomal abnormalities in the oocytes, literally increases. So this is interesting to note, because you can see that they might get pregnant, but finally having a live, healthy baby in their hand literally goes down. So what about the sperm? You know that egg, they're born with all the eggs that they have. Age matters, but what about the sperm? The sperm, on the other hand, starts production when in puberty. Millions of sperms are produced, so that's not a problem. But count is very important. You can have classifications about semen quality or the sperm quality based on the count. You can have men with 100 million sperms per milliliter, but if they're not motile or they are not having a good movement, then they will not swim and reach the eggs. So there you have a problem with infertility. Again, the shape, because you can see in the sperms, the shape of the head is somewhat tapered, which allows it to literally penetrate into the egg and cause fertilization. So these are parameters that are normally checked: the count, the motility, and the shape. DNA defects are also quite important. You can think about the sperm, it's very small, and you have a whole quantity of DNA that is packaged really tight inside the sperm. So DNA damages are very important. Smoking has been shown to cause a lot of DNA damage. And what happens when the DNA damage happens, or DNA gets fragmented in the sperm, you can result in a lot of miscarriages and pregnancy losses. So the whole process of spermatogenesis or spermiogenesis takes 64 days. So the whole sperm, from the time it's produced till it becomes functionally active, it's 64 days. This is divided into two parts. This is a cross-section of the testis, and you can see this is the testicle. You have the epididymis, or the tube that transports the sperm while you ejaculate. You can see in the testis, you have a lot of spaghetti-like structures called seminiferous tubules. And it is in these tubules the sperms are being produced. Then it's like a tube, or like a, I don't know how to say it, but like a row. And when the sperms are produced, they just swim through it, reaches into the epididymis. So the sperm production happens. Again, you have meiosis 1 and 2, and the haploid sperms are produced. Once that is done, that takes 24 days for it to get functional. So you start with a round sperm, it gets elongated, and finally ends up with a long-tailed elongated sperm with a head, a small neck piece, and a mid piece, and a tail. The semen analysis basically follows the WHO pattern. You look at, like I said, the count. You have to have a minimum of 15 million sperms per milliliter, and almost 40% of them should be swimming really fast. Any deviation from these values could be a cause for infertility. So causes of infertility in males, I explained it a bit before, but it's also interesting to see like some things like anabolic steroid use, heat stress, having your computers close to your body, cigarette smoking, age, all that also can be minor risk factors. But all these are acquired factors, like it can be factors that you can literally get or you can treat it. A typical examination of the male, look at his lifestyle factors. You can also do a genetic study, like you can also do like a karyotyping, look at his 46XY chromosome. In countries like Norway, where you have a higher prevalence of cystic fibrosis, you can also do special analysis. Male infertility can also be quite genetic. I think you might have heard about Klinefelter syndrome. XXY chromosome, they have an extra female chromosome or X chromosome, and that makes them have infertility. You can also have the Y chromosome. If there are microdeletions in specific regions of the Y chromosome, that could also be a result of infertility. Genetic reasons normally contribute around 15% of male infertility, so that's quite a good number. But one of the promising things about male infertility is that you can treat them with ART, but at the same time, you do not really pass it on to the next generation. So you're not creating babies that can have the same defects. We were talking about the egg quality and the count declining. The sperm count is also declining. And these are studies from the Western world. And you can see that the quality of the sperm has been declining as well as the count, due to definitely a lot to do with lifestyle factors and so on. At the same time, there's an increasing incidence of testicular cancer, which literally tells us that it's important to look, it's important to have a good lifestyle, follow your eating habits, stress levels, important to have friends, talk about things, and it's quite important in sharing things. So the sperm quality, again, a lot of genetic, but also acquired. Everything from your sleep pattern, having irregular sleep patterns, consumption of smoking and or alcohol and diet, stress, physical activity, all can have a effect on your sperm quality. So the maternal and the paternal contributions, the mother is very important. She gives, of course, her chromosomes, 23 chromosomes. The mitochondria, or the powerhouse of the cell, it comes from the mother. Whereas the father, he gives the sperm gives the haploid genome, so you get the 23 chromosomes, so that the baby gets 46 chromosomes. He also gives the centriole, which is very important because that's the one that helps in cell divisions. So from a one-cell egg, you have to have a baby with millions of cells. So how does IVF start? The egg pickup or the oocyte retrieval is the most important thing. So like I said, the woman undergoes stimulation, ultrasound monitoring is done, and when the doctor thinks she's ready to get follicles out, then you can see that the doctor inserts a needle, there's a tip of the needle, and then collects the oocytes. And the lab literally gets this follicular fluid. If you remember, I said that the follicle has a fluid and the egg hangs in it. So the doctor is actually aspirating this follicular fluid with the hope that the egg comes along with it. So the lab will check the follicular fluid to find the presence of any egg. And this is how it normally looks like. It's the egg with the multitude of cumulus cells around it. And these cumulus cells and the egg have a crosstalk. So this is how an egg looks when it's completely removed of all the cumulus cells, and it has its own cytoplasm. The outer covering here is called as a zona pellucida, and this becomes thinner and thinner as the egg increases in size. You also have the polar body, which is quite important because during meiosis, a part of the chromosome has to be kicked out. And this is why aneuploidy increases in aged females, because the polar body doesn't get kicked out. So it ends up having extra chromosomes in the egg. So what about the semen? So the semen analysis is quite important. I'll play this video. And these are all sperms that are quite swimming. So you can see that you can look at the count. You can look at how many of these are actively moving, progressive, and a percentage of, for example, in this case, you can see that almost 60% of the sperms are highly active. There's a good count. So in this case, the factor for infertility or the cause for infertility is probably not a male one. The sperm collection methods, when they come for IVF, you have the eggs collected. You also need the sperms to fertilize them. Ejaculation is the common one. If the man suffers from diabetes, sometimes he has a problem collecting, and instead of the sperm coming out, it goes into the urine. So then you have to take the sperms from the urine after treating it for its alkalinity. For paraplegic men, electroejaculation could also result in sperm production. If there is no sperm production in the testis and it's very low, then you might use surgical methods to collect the sperm. In some cases where the man doesn't have any sperm production, then use of donor semen is also suggested. So like I said, in men with very few sperm production, the doctor could literally, these are like the spaghetti-like things I talked about in the testis. So you can see these are thin tubules, these are thicker tubules, and these thicker tubules can be seen by the doctor using specialized microscopes. And these ones you collect, you tease it out and check for the presence of sperm. And that's how the sperm will look like, with a lot of RBCs and tissues and stuff. Then when you have the sperm and the egg, if the sperm count is quite normal, then you place the sperm and the egg together with the hope that the right sperm will swim in and fertilize the egg. All this happens in Petri dishes. And just to be very clear, these Petri dishes are all embryo toxicity tested. They're also like marked for CE testing. So there is always a risk in vitro fertilization, because if the sperm doesn't swim in and fertilize the eggs, then you have zero fertilization. So the actual process of fertilization is very interesting. If you are interested, I would suggest reading up on it, because in human nature, everything is about crosstalk and everything is about interactions. And that's also interesting. Like in our real life, if you think about it, talking, communicating, and interacting is very important. The egg and the sperm literally talks to each other. The sperm, as it swims and comes towards the egg, undergoes acrosome reaction, and that makes it, gets a hypermotility, so literally like showing off, and then it penetrates the egg. As soon as one sperm enters the egg says one is enough, because if you get more than one, then you can have more than 46 chromosomes. So then it creates a block so that no other sperm can come in. So this process of fertilization is quite interesting. In normal IVF, the sperm, you put almost 100,000 sperms per egg, and the sperm will swim in and do this whole process of sperm-egg interaction and fertilization. However, if the sperm quality is quite low, then if you put the egg and the sperms together, there's always a chance that it will not swim and it will not get fertilized. So then the embryologist has to assist the sperm to move inside the egg. So if you see in this example, this is called intracytoplasmic sperm injection. So you're injecting the sperm into the cytoplasm of the egg. So in this case, you can see the sperm is swimming. This is almost 100 times magnified. So you can see the sperm is very slow. You break the tail of the sperm, take it inside these minute pipettes. These are like 3 micrometer big ones. Then you go to the egg drop. This is how an egg looks like. You hold the egg. You can see the polar body here. So this is a normal, mature, good-looking egg. You hold the egg to these holding pipettes. And then you bring the pipette with the sperm closer to the egg. And you do the injection. So in this case, you're really sure that the sperm has gone into the egg. So you're trying to avoid one step where the sperm swims and finds the eggs itself. But in this case, you're trying to do the injection yourself. So you're really sure the sperm is inside. IVF units often have high-tech equipments. You have a lot of incubators, a lot of time-lapse machines. You use dishes, like I said before, that are embryo toxicity tested. You have to have the air quality to be really important. So this is basically, I think if you have seen stem cell culture clinics, you will see that it involves a lot of high-tech IVF things. So the fertilization happens when you saw the first egg with nothing in the middle. In this case, you can see there are two nucleus, one from the sperm and one from the egg. And that's the sign for normal fertilization. So once fertilization happens, you can really see that they are separate entities. The egg and the sperm nucleus does not mix. But the first sign of mixing happens at a stage called synchrony, where you can see that it has disappeared. And that's the beginning of cell division. So from here, mitosis starts, and it's a period of intense DNA replication and cell division. So how does the embryo develop outside the body? You have everything from fertilization until the stage of blastulation, or when it's ready to get implanted. So say, for example, 44 hours after you have put the sperm and the egg together, then you expect to see a 4-cell embryo. So embryo grading is very important. At the same time, the genome, the gene expression changes. In the beginning, it's the maternal genome, and then the embryonic genome takes over. So just to play a video, this is the whole embryo development that happens inside the lab. So you can see in this case, the sign of fertilization, where you have both of them together, disappears, divides to 2 cells. It's also how it divides, 4 cells. And one of the most important things in embryology is that timing is very important. Time when it gets fertilized, time when it divides, and synchrony, how synchronous are the divisions. So you can see in the 4th cell division, the cell numbers increases. Finally, it turns out to be something like a ball. And then you have cell differentiation, where it becomes a blastocyst. If you can also see that the outer shell begins to become thinner and thinner. Like if you remember in the beginning, it was quite thick, but then in the end, you can see it's, and in the end, you can see it's quite thin because now it's ready to come out, hatch, and implant in the uterus. So the blastocyst stage, this is the stage just before it implants. The blastocyst stage is quite important because the blastocyst has a thinner outer covering. It has these cells that are called the trophectoderm cells on the outside, and these become the placenta. So the placenta is quite important because that's what connects the mother to the baby. And then you have this one called the inner cell mass, which later becomes the embryo proper, or the baby. The inner cell mass is also the source of human embryonic stem cells. And this actually creates a completely new branch of medicine with stem cell therapy and so on. So this stage of blastocyst is quite important. If you think about it, I would say it's around maybe 300, 400 cells in a blastocyst, but a number of things happen during that time. You have the shift from the maternal to the embryonic genome. So that's why the mother's egg should be of good quality, because if it's not of a good quality, then the embryos are not good. We have a saying in IVF that we say garbage in, garbage out. So if the egg quality and the sperm quality are not good, then the quality of the embryo that it produces will not be good either. There is cell differentiation that happens. So you have the 2 different types of cells, the TE that gives the placenta and the ICM that forms the embryo. Embryo metabolism changes from being pyruvate metabolism to glucose utilization. So you have the Krebs cycle in the beginning, and the later stages it's glycolysis. You also have something called totipotent and pluripotent. I think you might have studied about it. So totipotent, in the beginning, when you have like a 4-cell stage, each of the cell could become a baby. Whereas when you go towards more later stages like the blastocyst, when cell differentiation happens, then you can only differentiate into 3 layers: the ectoderm, the endoderm, and the mesoderm. So like I mentioned before, in embryology, there are 2 things that are important. One is timing. When does things happen? When does it become a 2-cell? When does it become a blastocyst? I like to always use this analogy when I talk to my couples or the patients that if you have a baby who starts talking when it's 2 months old, then either it's a miraculous baby or there's something really wrong. And if the baby doesn't talk when he's 4 years of age, then you know that it's time to show a speech therapist. So that's exactly what happens in the Petri dish. You want things to happen at specific time intervals, and you want them to be synchronous. So if you have a 2-cell, the ideal situation will be to see that both the cells dividing at exactly the same time, so you don't have any other cells in between. So synchrony and timing are 2 important things in embryology. It's always fascinating because you can think that, say, a woman comes up with 10 to 15 eggs, the couple's sperms, but then you can see that each embryo is unique in the sense that each embryo has its own morphology or the way it looks, but it also has its kinetics. Like I have never seen 2 embryos behaving exactly the same way, even if they are twins. The way they divide, the timing at which they divide is quite different. So it's not just morphology that we look at, but we also look at the kinetics of division. So morphokinetics is more important. We were also lucky to be a part of the international group that set guidelines for this one. And we've also looked at how we can predict or how we can use these morphokinetics at predictive models for live birth. So once you have these embryos, then the next thing is to put them back. So how do you put back these embryos? The doctor literally uses, this is the ultrasound. So you can see this is the uterus and this is the bladder. So this whole thing is a bladder that's pushing the uterus down. The doctor uses thin plastic catheters. They're not really plastic, but embryotoxic tested plastic. And then he tries to put the embryo in the uterus so that the embryo now will stick to the uterine wall and the uterus is ready. In the normal menstrual cycle, the corpus luteum gives the progesterone, but in an IVF cycle, you have to supplement with progesterone tablets. Another important development that has happened with IVF is, as IVF became more and more efficient, it resulted in a lot of good quality embryos. And each embryo has the potential to give rise to a baby. So you don't want to literally throw them away. So you can definitely freeze them. Now it's possible to freeze individual sperm cells, testicular tissue, especially if it's a young man and he has testicular cancer. He still has a hope of getting a child after his cancer is cured. You can freeze eggs, embryos, blastocyst, ovarian tissue. You can also, you have heard about proactive freezing, or the common term being social freezing. Companies like Facebook and Google, they provide their employees with the ability to freeze their eggs so that they can concentrate on their careers and have babies at a later age. It's questionable, but at the same time, that's how the world is now. You can do assisted hatching using laser. So you literally make a cut in the outer zona, and this will result in the blastocyst coming out and hatching. So you're assisting in the hatching process. There's also the whole multiple thing about third-party reproduction. If the inability to conceive is a sperm factor, then donor sperms can be used. The same with egg donations. In countries like UK, even embryos are donated. Partner donations for lesbian couples, because you can take eggs from one, put the embryo back in the other, surrogacy and so on. Of course, all these are different ways by which couples can have children. They all have their gray zones. So it's important to notice or to read about it and see how you can do things ethically, correctly. And in most countries, including India and Norway, we have a lot of restrictions and rules and guidelines on how IVF should be conducted. So we no longer define family as in IVF as being a baby born to a husband and a wife. You have all possible combinations of using a donor oocyte, using a donor sperm, having a surrogate, and so on. So the definition of family has completely changed. So when you think about it, IVF is all about collecting eggs, checking them, helping them get fertilized, culturing them, selecting the best embryo, putting them back, freezing the remaining ones, and then looking at success rates. So what is success? Of course, success is when you have a healthy baby in your hand. And the whole process of IVF, even though it's quite efficient, it's not completely efficient. A number of factors could result in helping a couple get pregnant. It could start everywhere from the number of oocytes she's born with. If she's not born with a large number of oocytes, then there's a problem, because with each menstrual cycle, she will lose a set of eggs. At the same time, it could also be that with age, these have more chromosomal abnormalities, so her chances of miscarriage can be more. The same with the male factor, because you can have sperm production, but with lifestyle habits and genetic factors, the sperms may not be so efficient. Not all eggs that we collect are mature. Not all of them get fertilized. Not all of them give rise to good quality embryos. And even if they implant, you can say that not all of them results in a baby. So here we are talking around 30 to 35% chances of a couple coming to an IVF clinic going out with a healthy baby. So this is what we are trying to increase every time. And the quality control of an IVF lab is quite important. Of course, it matters a lot with what we start with. So if we start with older couples, if we start with severe genetic factor, that can have an effect. But the laboratory also is quite important, because how you manage, how you handle the eggs and the sperms is very important. The air quality, how you manage and maintain your incubators, the number of embryos that you transfer, the luteal support, all these factors are important. One of the best things about working together in an IVF lab is, without a doctor doing a proper simulation, you will not get good eggs or sperms. And if the lab is not good enough, or the embryologist doesn't do his function, then you will not have a good embryo. So it is actually a combined effect, and that's one of the best things I like about IVF, is it's like a teamwork. The doctor, the IVF specialist, the nurses, the counselors, the embryologist, all work together so that the couples get a baby. There are a number of factors that can affect ART outcome. Everything from the woman's age, which is the most important factor, the duration of infertility. If you remember, Louise Brown had the parents had 9 years of infertility. Whether it's a primary, have they had children before? So then it's secondary. If they've never had children before, then there's a more difficulty in making them get pregnant. The diagnosis, is it a genetic factor? Is it an acquired factor? Have they had a lot of previous failed attempts? Like I said, garbage in, garbage out, the quality of the gametes, the number of embryos transferred, and of course the endometrial receptivity, endometrium or the uterine lining. If you look at IVF, it's quite interesting, because you start with a crosstalk. You start with a crosstalk between the egg and the sperm. During fertilization, there are a large number of genes that are involved that will allow this communication to happen. There's a communication between the egg and the cells around it. The sperms, there's a communication between the embryo when it finally reaches the uterus, because this crosstalk is important and it is receptive. And like 50%, if you have a good embryo, you have a 50% chance that the endometrium is not receptive. So this is basically what IVF is about. I hope I have been able to give a bit of an understanding about how IVF works, and I'm ready to answer any questions. Hello?
Now we have a question and answer session. Please post your queries in the chat box, or you can unmute and ask your questions to the resource person directly.
Hi, ma'am.
Yes? Hello.
Hello, ma'am. I am Nandu.
Hi.
Hi, ma'am. Okay. How you choose this route? What are the challenges you face become an embryologist?
I'm actually a molecular biologist, so I did my master's with Ligi, and that's how our friendship, and we have many years of friendship together, and that's how I started. But I'm trained to be a molecular biologist, so I was actually working in the genetic lab, and then accidentally came across IVF, and then thought this is not a bad thing. Like, it's a highly, I don't know, a rewarding profession. It has its ups and downs because you want every couple to be pregnant, but that doesn't happen. That's not how life works. But there are a lot of challenges because you have to have, I would say that you have to grab opportunities. You have to be very methodical. You have to be very systematic in what you do, because you can see that it's a matter of life. Like, you are trying to help somebody have children. So it's very important that you do things systematically. If you are used to working in labs with good precision, then embryology is a good field. It's also stressful because you want, it's always result oriented in a way, because you want the couples to be pregnant. It's not just that they're investing their money in it, they're also investing their whole I would say life. It's a lot of stress. It's a lot of psychological effects on the couple. So, however, at the end of the day, if you think that you have done things correctly and you're trying to help, I think it's quite rewarding.
Thank you, ma'am.
Thank you. I think I have.
Ma'am.
Yeah, I'm sorry.
Yes, ma'am. You have a query in the chat box.
What are the potential side effects of undergoing IVF? You would read a lot about side effects, and just like the video said, the side effects are very low. Now there's a huge study going on in the Scandinavian countries called CONARTS, and it literally says that the babies born after IVF is no different from any other baby born. You have to undergo stimulation. In the early days, these drugs were not so effective. So you had a lot of side effects, and there were studies in the beginning showing that probably there's a chance or increased chances of having ovarian cancer and so on. Now that doesn't hold any effect. I'm sorry. The drugs are quite effective. The media that is used are so tested. So I would say the side effects are very, very minimal now. Will there be any defects in the frozen embryo? No. You can freeze the embryos. The sperms can be frozen for hundreds of years because you're literally stopping the metabolism and you're starting it again. The same with the embryos. Different countries have different rules. In Norway, you can have them frozen until you turn 46 years, but that's because you can't expect somebody to have a baby when they're 60 years old. So that's the age limit. I don't know the age limit in India. I'm very sorry. But you can keep them frozen forever, basically. And you're freezing them in media that's tested. You're doing rapid freezing. So you're literally stopping metabolism for some time. How can you relate PCOS or PCOD with ART? PCOS or polycystic ovarian syndrome is one of the causes for infertility. PCOS can be quite genetic, but it can also be acquired. The difficulty with PCOS is basically that they have a lot of follicles. So when they have a lot of follicles, when you if you don't stimulate them, then the eggs have a problem maturing, or when the eggs do not mature, they stop at some stage. So you can say they grow, but then they never become completely ripe, right? So you can do IVF for them so that you can control with ultrasound monitoring and see how the eggs have ripened. But because they have a lot of eggs, not all the eggs would be really good quality. So PCOS is really treatable with IVF. But of course, it has its challenges because you can have a multitude of follicles. And when you have a lot of follicles, you're not really sure whether they are mature. Is DNA test mandatory for an IVF baby? No. As long as you, I think IVF clinics have a responsibility to make sure that they use the right sperm and egg. So it's not mandatory. We do DNA test on the sperm. For example, if in unexplained infertility, you remember, like I said, 20% of the cases, the infertility could be unexplained, which literally means that you do not know a reason. So say they come for the first cycle of IVF, there's no specific reason. So you expect them to produce good quality embryos, right? But you see that the embryo quality is not so good, then you would literally want to try and see, does this man's sperm have a lot of DNA damage? So then you could do a DNA damage test or a DNA fragmentation test on the men. And what happens is that, say, for example, a man with a normal count, motility and morphology, so it's not a male factor evidently, but you could also say that, why is he not producing good quality embryos? One of the things with the sperm is that you can always test it out. Whereas with the egg, you have just one egg per menstrual cycle and it's quite precious. And you, like I said, the girl is already born with all the eggs that she has ever produced in her life. So that's the thing, but otherwise we do not do any DNA test. Other still ethical issues related to ART. Of course, there's a lot of ethical issues. Regulations and restrictions are very important. Everything from surrogacy, because reproductive tourism, you have tourists traveling to, say, for example, to India and other countries to do surrogacy. Third-party donations, donor sperms, like, you can use donor sperms, but in countries like Norway, it is completely non-anonymous, which literally means that the child, when he is 15 years of age, has every right to find out who the donor father is. So literally, you are looking at the child's welfare and you say that it's important for him or her to search for the donor father. So it's non-anonymous. So a lot of ethical issues, starting from how you do things, not mixing of sperm and eggs. You don't mix different couples' sperm and eggs. Everything is ethically quite important. Is there any risk of low birth weight in ART? There is a risk of low birth weight in ART, not a statistically significant risk. There is a slight risk, and that's probably because of, there have been studies that say that's stress related, but not too much. It's slightly smaller. The ART babies are slightly smaller, but when studies are conducted when they're 5 years of age and 10 years of age, basically, there's no difference in their cognitive development. And actually, they're supposed to be more smarter, just to say. And why are they more smarter? There have been psychological studies about it. It's not that we create super babies. It's just that parents, because this is like a long child, the parents put in more effort. And this is a study from the Europe. So you literally put in a lot more effort bringing up the children. Many women now claim, the question is, But I've noticed that many women now claim to consume their placenta because other mammal females consume it postpartum. Is this really a good practice? Millie, I'm not really sure about it. Personally, I don't think so, but I'm not really sure. I haven't thought much about it. Yeah, no, why not? Placenta is a good source of stem cells anyway. Can ART result in premature birth or ectopic pregnancies? ART does not result in premature births, but you have to remember that these are infertile couples. So there is an underlying factor of infertility in them. There is something that makes them infertile or subfertile, right? So they often have some endometrial or uterine defects. Premature births can happen, for example, if the uterus, instead of being like a round, if it is heart shape with a big septum in the middle, or then the embryo can attach to the septum. Then when it grows, you can see that it doesn't grow so big, because if it's a structure like this, then it will grow and the embryo can develop. But when it grows in a structure like this, if the uterine anomaly, then it won't become bigger, and that would result in premature birth. So that can happen. Ectopic pregnancies, that's tubal pregnancies, all those other, but I would say it's less than 1% chance that it happens due to IVF. Is there any other question? I would say that this is, I assume that most of you are studying biotechnology. I would say that this field is quite interesting, or it's very interesting, because it actually brings in a lot of things together. You have a lot of genetics. So if you're interested in genetics, it will provide you a lot of answers. If you're interested in molecular biology and biotechnology, then it's quite the field to go to. Biochemistry, like I said, small things like you shift from a Krebs cycle to a glycolysis in the end. Microbiology to some extent, because you're culturing and the aim is not to have bacteria and so on. So it's a branch that, and a lot of ethics, law, you have legal guidelines on how to do things. So it's a branch that actually does, I forgot to mention about histology, because if you're interested in pathology and you're interested in doing pathological studies, then for example, in men where there's no sperm production, you take the testis biopsies and then you send it for histological studies to see whether there's sperm production. So it's a multidisciplinary field. And it's quite rewarding. And I ended up from being a molecular biologist to being an embryologist, and I don't regret it. And it is something, it's also, like I said, a teamwork, especially now with the pandemic. You know, it's quite important that we talk to each other. And embryology gives us a lot of life lessons, because in embryology, everything is about crosstalk, communication, communication starting from the follicles to the oocytes, the eggs talk to the cells around it, the egg and the sperm, the embryo talking with the endometrium. So it's so important that even during this pandemic, it gives us life lessons like talk to your friends, keep your relationships. You learn a lot, and it's such an interesting field that even from gene interactions, I would suggest that if anybody is interested, this is the perfect field to go through. So the next question is, what is the chances of successful births in a male pregnancy? I think maybe you're asking about the chances of a successful birth. If you talk about live birth or the ability to have a baby in your hand, of course it's age related. For younger children or younger women or younger men, then you can almost say 50-50. If she is around 28 years of age, the slightly factors that we are trying, and always remember, we are trying to overcome infertility. We are not trying to cure infertility. You're trying to cure infertility to some extent, but you're trying to overcome infertility issues, right? So the chances, they say, is around 30 to 35% on a general basis. And general basis includes couples 40 years of age, 25 years of age, and so on. So that's how it is. How many times we can do IVF if the couple needs a second baby? It depends. Normally like I said, in Norway, because infertility is considered as a disease, not a disease, but it is in the group of diseases, you get complete government funding. So people get 3 attempts of IVF completely free of cost. So you can see some couples, it's a lot to do. Like it's mentally stressful, mentally draining. Sometimes couples stop after 1 attempt. Sometimes they carry on for 10, 12 attempts. Normally we suggest them to take 1 attempt at a time. If the embryos are not good quality, then maximum we tell them to try 3 times. If after 3 times, if things doesn't work, then they definitely will have to talk to the counselor and the IVF specialist and take things from there. Of course, if you have somebody producing good quality embryos, I always believe that sometime or the other, they're going to have a baby. You know, it's just a matter of time. The time to pregnancy is very important because you can have, it's called TTP in IVF. TTP means the time to be pregnant. So the time to even I forgot to mention it in the slide with the semen analysis, the time to get pregnant for a semen or the sperm is very important because people lose hope. And when you lose hope, then you get stressed out, and all stress can affect the quality of the gametes. So time to pregnancy is very important. And it also depends upon how much you can tackle the whole stress situation, right? Is there anything that could negatively impact IVF success? Lifestyle, smoking, alcohol consumption, drugs, talking to each other helps. Counseling is important. If you have a genetic factor, that could negatively affect for somebody like having a Klinefelter syndrome, having an extra X chromosome, the sperm production would be almost minimal or 0. So awareness is very important. A lot of factors can affect it. Are there any restrictions while undergoing IVF? Not really. The restrictions are mostly, I wouldn't say restrictions, it's mostly taking your injections at the correct time, following the doctor's instructions, have a lifestyle, have a healthy lifestyle. Normally we see couples just before the IVF treatment going into a full-on diet package and stuff like that, and that's not so good. But otherwise, no restrictions. People here, they come for the egg collection, go right after that for work, come for the embryo transfer, go right up. Live a normal life. Try not to have too much stress in your life. I forgot one of the questions about it. Does the process change if using donor egg and sperm? Of course, it changes because it's not your biological child, right? If you think about it, you're using donor eggs and sperms that are not biologically related. One of the biggest challenges in using donor eggs and sperm is that maybe it's not so much for the couple, but we encourage our couples to be really open. In Scandinavia, there's this tendency that we tell the couples to tell their children if they're conceived using donor eggs and sperms around the age of 3-4 years, because then it's easier to slowly tell them about this, so that when the child grows bigger, they already know that they're not biologically, this is not probably their father, can't say father or mother, but this genetically they're quite different, but then they get used to it, and then the hope of finding out the donor is not so much. Whereas if you literally hide it from the children, now like people do a lot of ancestry searches and so on. So if they suddenly find out, then the trust factor goes out. So in Scandinavia and Norway and countries like this, donations are non-anonymous, which, like I said before, 15 years of age, the child has every right to go search for the donor. The donor has the right to not visible, like he has the right to say, I don't want to meet you, but I wouldn't mind sharing my details. So the donor is also protected in some way, that suddenly, you end up having 10 children on your doorstep saying, I'm your child. He doesn't have, or he or she who donates the eggs or the sperms doesn't have any moral obligations or any, they don't have to give their money or the things to the child. But of course, it's necessary for the child to be, it's about transparency and openness, right? So that's one of the factors. Otherwise, I think donor children are no different. Does the duration of frozen egg or gametes affects the success rate? No, it doesn't. You're freezing the eggs, and what you're trying to do in the freezing process is trying not to create ice crystals, because when you remove the water content from the eggs or the sperm, and then you add cryoprotectants to it, because if you have water, when it freezes, you will have ice. And when it thaws or when it warms up, then the ice just expands and destroys the egg. The process of vitrification or the process of freezing now is so advanced that you can get actually better results with frozen eggs and sperms. Is there any health issue in the mother which is different from normal pregnancy? Not really, but if she has an underlying factor, say for example PCOS, then she has to be really careful about her diabetes. Gestational diabetes during pregnancy can happen. It's just normal pregnancy. Once they get pregnant, they never visit us again until and unless they come back with the baby. But otherwise, it's just continuing with your normal gynecology checkups and living normally. That's it. I hope I haven't missed out any questions in the beginning. If there's something, I hope, Manju, you can just tell me if I missed out on some questions.
No, ma'am.
Are you all students of biotechnology, or did you hear about IVF before? I know IVF is quite common, like it's commonly used term, and India is doing a lot of IVF work. Is this something that you guys are interested in, like taking as a profession? Is there some other questions?
I think we have come to an end of the question answer section. Thank you so much, Mom. It was an enlightening experience listening to you. The session was very informative as the students of biotechnology. The session provided us clarity regarding the assisted reproductive technology.
Thank you so much. It's not so easy to, concise a full branch of medicine and biotechnology into a 45-minute lecture. I just wanted to give you an overview. And it's also important that it's one field of medicine that you can definitely think about. There are a lot of IVF clinics coming up, and students with a biotechnology degree are often preferred. Always keep your options open. Look out for opportunities. Grab all the opportunities that are available to you. And that's my advice, like keep your relationships closer. I'm extremely happy and thankful that I've been invited to give this lecture. And when Dr. Lee Ji says something to me, I never say no. So friendships are equally important. And I'm extremely thankful to the department, the head of the department, for giving me this opportunity. And I hope I've encouraged somebody, one or two of you at least, to think of this field as a profession later on.
Now, let me invite Nandu Anil Kumar to deliver the vote of thanks.
Good morning to all. Assisted reproductive technology encompasses a wide range of techniques designed primarily to aid couples unable to conceive without medical assistance. Since the birth of the first baby in 1978, more than 1.5 million children worldwide have been born following IVF treatment. I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. Let me, first of all, start by giving glory to the Almighty for making today's occasion a resounding success. First and foremost, I thank our speaker Shabana ma'am, who despite her busy schedule has found time to present an overview on assisted reproductive technology. Her talk was really inspiring, and the way she propounded the subject helped us in understanding the concept even more better. I thank our principal Father Reggie P. Kurian and our director of self-financing section Father Teddy Kanyu for their unstinted support for this function. We are grateful to our head of the department, Mr. Chauvin Varghese. His able guidance has interest, hospitality, and continued support. I owe special gratitude to the coordinator of the whole program, Dr. Liji Jacob, who has worked hard to ensure the occasion becomes a memorable success. My heartfelt thanks to the faculty for their valuable contribution, guidance, and encouragement in all the efforts. I thank all the invitees present here accepting our invitation. Last but not least, I thank you, my friends, for your cooperation in making this function a resounding success. Once again, I thank you all for your attention. Thank you.
Sorry for
Thank
the
you, Shabana
instruction.
ma'am, for your valuable suggestions and your valuable time. Thank you all. Thank you. And we'll be waiting to see you on next Saturday. I think one or two students are really interested in the IVF field. I think Nandu said is interested in IVF field. He talked to me earlier about asking about IVF and how he can manage to get a job in IVF at all. I think Nandu can ask lately about the procedures of going outside to study about these things. Uh, I think it was a very good and very informative session, and students, all students asked so much of questions. I think we can go for a bigger audience after 1 or 2 months, I think.
Thank you. Just let me know, and I'll make sure that I can assist students like Nandu or like anybody. I think it's quite interesting. Today was just an overview. Next week is about how you put it into practice, from everything from artificial intelligence and genetic testing. Those are all fields. Like it's not just one field. It's all biotechnology, from cloning to you're even trying to put a mouse sperm in the space. So I'll try to make next week quite interesting about the practical parts of how we do IVF. Or, IVF is just a small field of the whole ART.
Yes, ma'am. That is a notice. Sorry for the instruction regarding the feedback form. The feedback form will be provided at the end of the second session, and the second session will be on 30th October at 10 a.m. We kindly request all of your participation for the session. And once again, thank you all and have a nice day.
Thank you.